That was an insightful and thought-provoking session. Now we'll move on to the last session of the day. That is another session on pediatric hepatology, for which I invite the chairpersons, Professor Anil Dhawan sir, Professor Sadhana Lal ma'am, Dr. Anjeev Khanna sir, and Dr. Chennakeshava sir. I humbly request the chairpersons to take over the proceedings and invite the speakers for the talk.
Thank you. Thank you, Keshav. At the onset, I must thank the organizer, INASL, for giving me this opportunity. This is my real privilege and honor to speak in front of my mentor, teacher, and teacher's teacher, Professor B.N.S. Walia. As Anil said, that so many of us are sitting here, have been taught and mentored by Professor Walia. I am really honored to speak in front of him. I have been asked to speak about the managing indeterminate acute liver injury and acute liver failure in children. Let's clear the doubt about what is this ALI and ALF in adults and children. We have clear-cut definition of acute liver injury in adults. This is the definition given by acute liver failure study group. This is a counterpart of the adult group. Rather, we have the pediatric group. They have the adult acute liver failure study group. They said that acute liver injury of two types. Either it is in the setting of acetaminophen or non-acetaminophen. If it is a non-acetaminophen, then you take in account of the bilirubin more than 3, AST-ALT more than 10 times, INR more than 2 but without encephalopathy. And in paracetamol, it is you ignore the bilirubin, rest are same. Without encephalopathy, if you have the INR more than 2, then you call it acute liver injury. And acute liver failure whenever there is encephalopathy. More than 1.5 INR with encephalopathy, it is a acute liver failure. But we have a clear-cut definition given by our pediatric acute liver failure study group, which is followed everywhere. In children, INR more than 2 without encephalopathy also we call it liver failure. So here we are. We don't have anything called acute liver injury. ALI in adult is more than 2 INR without encephalopathy. In children, the same with more than 2 without encephalopathy called ALF. Right? We have some loose definition people have used in pediatric studies. One of this group, I am going to talk about this study about indeterminate severe hepatitis. Severe hepatitis means they have taken AST-ALT more than 500, INR less than 2, obviously without encephalopathy. And most of us are familiar with this WHO definition of severe acute hepatitis of unknown etiology. Again, it is a ALT-AST base more than 500. No INR is taken into account, and the age is less than 16, and this is a specific definition for that particular entity. So we have a gray zone about the defining ALI. So most of my talk will be on indeterminate acute liver failure. Now what is the experience of etiology of acute liver failure in children in India? See, they have collected the studies from all over India, starting from Chandigarh to Calcutta, Pune, Delhi 2 studies, and Chennai 2 studies, and across the board in India, in children, acute liver failure we get predominantly viral and predominantly hepatitis A. So my talk is about the indeterminate. How frequently we get? We get indeterminate is around 15 to 20% of the cases. It varies. When I did the study from Chandigarh, we didn't get it. It's predominantly viral hepatitis, and then Rajiv Center ILBS got around 20%. So around 15 to 20% we get. But this figure is much less than what has been published from the Western countries, especially the pediatric acute liver failure study group. Now, this is a very important group which was formed in 1999. Pediatric acute liver failure study group predominantly is from America, 24 centers, 21 from US, 1 from Canada, 2 from UK. Basic purpose was to generate the database. And they started collecting data from 1999. In the first phase, they have collected 348 cases of acute liver failure. 1/3 of them are less than 3 years. And you see the indeterminate defined by no specific diagnosis could be reached of that point of time the type of investigation they have done, right? And then if you see the analysis, they have, like what we talk about, 50% viral hepatitis predominantly A. In their study, it is just 1% viral hepatitis, just 3 cases of A and 1 C, and rest of the other viruses. But almost half of them, almost 48.6%, are indeterminate. They couldn't find out the etiology as per the protocol of investigation at that point of time. So the question came, and if you see the natural history of indeterminate, they have a relatively poorer outcome. That means spontaneous recovery around 43% versus overall 47%, though it is not statistically different, but definitely in paracetamol induced the outcome was better, but need for liver transplant was much more. 46% of indeterminate acute liver failure, they require liver transplant, compared to the overall it is around 32%. I come to that why they are requiring more liver transplant. Means if you see the clinical feature, you cannot discriminate that in indeterminate acute liver failure versus where diagnosis is known. Clinically, there is no parameter can differentiate. But the main issue is the uncertainty about the clinical course. When you are treating a acute liver failure, you have very little time to take a call whether patient should be transplanted or not. Either patient will die or you have to take him to the transplant. So this uncertainty is very much driving force for doing more liver transplants. Especially the King's College criteria has given that non-A, non-B, so-called that indeterminate has a poor prognosis. So everything is together. The people are forced to take an early call to do liver transplant indeterminate without. Anil showed that some of them probably we are overdoing. So probably this is a subset of patient where liver transplant is done more often because of uncertainty about the diagnosis. We don't need the diagnosis. That's why we need to do more investigation. Now, by definition is no diagnosis without complete evaluation. But what is complete evaluation? So that point of time, whatever they were doing probably is not complete. So now this pediatric acute liver failure study group, they decided in the year 2012, no, we need to do a detailed age specific test. They call the age specific diagnostic test, because in adult you have a set etiologies of acute liver failure. In children, these are dynamic. If you talk about a neonate, liver failure is different. If it is a young baby less than 3 years, etiology will be different. More than 3 years, different. So it should be the age-specific diagnostic test. Like you don't want to do Wilson disease investigation in infant with a acute liver failure. So they integrated it in their electronic medical record based investigation system. Whenever on those pediatric acute liver failure study group, patient is diagnosed as acute liver failure, you put it, the age, immediately they will show the detailed investigation what you are supposed to do, and that will be generated. So now we have this the data sheet of pre and post implementation of age specific diagnostic test, and they have shown clearly when you implement, when doing more detailed testing, then there is significant reduction of this indeterminate group. From 48% it has come down to around 30.8%, and simultaneously liver transplant requirement also reduced from 35% to 20% without any change in the mortality. These are the detail about the various age-specific diagnostic tests. But what I have highlighted, when you are dealing with a liver failure in a first 90 days, less than 3 months, you are looking for herpes simplex, metabolic gestational lemon disease. Between 3 months to 3 years, again metabolic liver disease along with the paracetamol and autoimmune, and obviously more than 4 years, you will add Wilson disease workup. Now these are the parallel bars showing that different age group, when it is less than 90 days, 90 days to 3 years, and more than 4 years, the pre and post the age specific diagnostic test, what is the difference? The maximum difference they got in the older children, the indeterminate etiology has reduced from 44 to 24%, and that is because you are diagnosing more and more acetaminophen and occult acetaminophen induced liver failure, and also HLS, hemophagocytic lymphohistiocytosis, and the figure for this group is less than 90 days is gestational lemon disease, we are diagnosing more, herpes simplex diagnosing more, and in the middle group up to 3 years is the metabolic. Now, this is not enough. We have reduced the number by doing the age specific diagnostic test from 50 to 30%, but still a huge 30% are indeterminate. That is the driving force for doing more liver. We have to conserve a precious resources. Uh, so, but how you can do it? So, in adult studies, it has been shown by doing the 3 steps. One is deep sequencing, means this is metagenomic next generation sequencing for virus. You can identify more and more viral infection. Then instead of doing the just acetaminophen level, you go for acetaminophen protein adducts, because acetaminophen protein adducts is a last in the blood longer, 1 to 1.5 days. You will pick up more and more occult paracetamol toxicity and adjudication. I'll show you that they have able to reduce the number of indeterminate by 50% by doing these 3 steps. But in children, what we are looking for? We are not looking for adjudication part. We have already formulated guideline how to diagnose especially different entities. What we are looking for? Newer thing like monogenic disorder by genetic testing and the immune dysregulation as a part of causing indeterminate autoimmune hepatitis. So either it is a incomplete testing that we have shown indeterminate, that we have reduced the number by doing detailed testing, several diagnoses together, so you are confused, so you are not putting the level or true indeterminate. And this is this adult study where they have done this adjudication and they have done use that sample, preserved sample for deep sequencing and paracetamol adduct, and they reduce the number. Now let's talk about that in children, how you can do it. The two way. One is we have to look at one angle is that the immune dysregulation is responsible for this subset of patient of indeterminate, and this concept came from this discovery of hepatitis associated aplastic anemia. What they have shown, if the children has developed liver failure today, recovered after 2 to 3 months, they are developing bone marrow failure, and on investigation found these are all immune mediated, especially the T cell mediated. So this is the first study came from Stanford University and shown 9 children with indeterminate acute liver failure where liver biopsy tissue was available. They did the immunological testing focusing the T cell population. 7 out of 9 of them have some marker positivity raised, IgG or CD4 CD8 ratio. And when it did the liver immunohistochemistry, there is the numerous CD8 positive T cell. And they have treated these children with IVIG followed by methylpred. 5 of them recover and 4 of them requiring bone marrow transplantation. And what they have said that immune dysregulation is a part of this indeterminate acute liver failure and which may respond to the treatment. So coming to the next study of immune dysregulation, this is from Pediatric acute liver failure study group. 37 indeterminate they have compared with a 18 diagnosed pediatric acute liver failure while liver biopsy tissue are available. Again, they are looking at this, doing the immunohistochemistry, then the liver biopsy, and also the TCR beta sequencing to see the clonality of this T lymphocyte. So what they have shown, there is a dense CD8 positive T cell staining like what previously shown in this indeterminate group than the diagnosed group. And most interestingly, they have shown this the T cell receptor beta sequencing. These are all antigen driven. There is a clonality, not the just non-specific inflammation. So they said that CD8 T cell staining should be part of our biomarker in indeterminate acute liver failure. Whenever you have the liver tissue, you should look for it. Not only that, they put this level, the entity called activated CD8 positive T cell hepatitis in this subset of indeterminate. Now, what is the therapeutic implication? This is the study published recently in 2025 from Atlanta. This indeterminate severe hepatitis, they have taken 14, and then they have this time instead of liver, they focus on the blood. Flow cytometry and plasma cytokine profiling. They have shown that amplitude of the CD8 T cell activation, which predicts the progression of indeterminate severe hepatitis to acute liver failure. What they have shown that 50% of children who are having very high T cell activation in the blood, they progress to liver failure despite being on steroid. Not only that, they gone ahead and measured the plasma concentration of the cytokine induced by the interferon gamma, which are elevated, and levels are similar like HLA, what you get in. And now they have done a intervention. They use the interferon gamma blocking monoclonal antibody emapalumab, in which is effective in HLAs. They use in 3 children and shown to be useful. So what they're telling, the CD8 T cell activation markers, like which you can, so far we are focusing on the liver, you can do it in the blood, like soluble interleukin 2 receptor activity is indicator of CD8 T cell marker. Easily we can do it. So all these markers it can be done in indeterminate group, and then we can decide whether we should intervene or not. Rest is the gene therapy. Just couple of slides. Indeterminate role of genetics. Now again, this came from just 2015, the discovery of the gene for recurrent acute liver failure. This is that neuroblastoma amplification sequence which was associated with recurrent acute liver failure, and then people have started focusing, yes, genetics might be playing an important role in this indeterminate group. So this is the study from Anil Center. They have used the targeted sequencing that time, not that whole exome sequencing, for 45 children. And what they have shown, in 27% of the cases, they have homozygous or compound heterozygous mutation present. And as expected, either this is a neuroblastoma amplification sequence causing recurrent acute liver failure, or rest are mainly it is a mitochondrial gene. So in pediatric acute liver failure, the problem is that doing the genetics is that we have a very little time. You cannot wait for 4 to 6 weeks till your mutation study comes. So the focus is not, effort is on to develop a rapid sequencing pipeline so that you get a report earlier than within 2 to 3 weeks. But that is not good enough. So now this is a bigger study. This is a multicentric study done in Germany from 19 countries, and predominantly from UK, Germany and Japan. Whole exome sequencing they have done and shown 37% of indeterminate acute liver failure, they have some mutation positive. And again, they have categorized them. What type of disorder? Predominantly mitochondrial. 45% are mitochondrial, almost 28% are vesicular trafficking, like that include that recurrent acute liver failure, and the rest are the others. So indeterminate acute liver failure is large contribution of the genetic causes, and they argues for exome sequencing, and probably in near future we are going to get a not the exome sequencing, we are going to get a rapid genome sequencing with report may come in 24 hours time. The main hindrance is that huge investment cost, and this is demanding amputation computation power which is hampering the availability. But I'm sure the center like the King's College will start this kind of rapid gene sequencing in near future. I don't need to talk about this entity. Fortunately, we get out of this problem that severe acute hepatitis of unknown etiology came immediately after COVID epidemics. I have given the definition. Around 10% required liver transplant and 2% mortality, and there is an association of this entity with adenovirus and adeno-associated virus too, which is basically incomplete virus needs the other virus to cause the disease. So to conclude, a significant proportion of acute liver failure still are indeterminate despite doing the age-specific diagnostic testing. Overall outcome is poor, and they need more liver transplant because of this uncertainty related to this entity. And what we need to now focus on, probably rapid sequencing gene testing to get some answer, and we can decide which patient should go for transplant, which patient is not. And probably this entity needs more focus doing as and when we have the liver biopsy, we can look for the CD8 T cell activity. Otherwise, we can do the blood CD8 T cell marker, and probably we need some more information before embarking on any therapy for this entity. Thanks for your patient hearing.
Thank you, sir, for an enlightening talk. So next, I would like to invite Dr. Neelam Mohan, who is the director and head of the Department of Pediatric Gastroenterology, Hepatology, and Nutrition at Medanta, Gurugram. So she will speak on sarcopenia and frailty in children and impact on outcome.
Do we have a pointer or straight away from this thing we have to do? Okay. Cursor computer. Fair enough. Thank you, chairpersons, and I would like to thank the organizers for this beautiful new type of talk because it made me read a lot. Normally, you're just so I am going to talk about what is sarcopenia, what is frailty, explain why this is relevant in children because we started talking about it in adults with CLD and this, and why this increasing interest in this field. So when we talk about the prevalence of sarcopenia and pediatric chronic liver disease, whatever the emerging data in the last few years, as I'm going to talk about the years that we are saying, they say it's almost 40% in some cohorts, including those who are waiting on the list. And what is the relationships, how it is giving rise to mortality, or is there any complication, or is it related to stay, is it related to healing, is it related to infection? Let's see. Typical scenario, 1-year-old, you can see Kasai post intraostomy comes to me with recurrent cholangitis, abscess, multiple hospitalizations, prolonged antibiotics, and is referred for transplant. Now, this child immunodeficiency has been ruled out. It's the liver which is giving rise and is less than the third centile. And so we typically like to see the weight, height, weight for height, mid-arm circumference. And that's what we've been talking about for decades and nothing more than that. And this is another child who's 15 years old, and look at his muscle mass. He's a chronic liver disease diagnosed and is referred for liver transplant, Kikaxake. Now, this child, what is sarcopenia and what is frailty, we'll talk. But some index I've talked about it, that it is less than the fifth centile. And I'll take you more into this story. What I mean by this CT, the psoas muscle area that I'm talking about in this patient. So this was a video where we are trying to make him walk and how he's walking, and the video is not working in this. So sarcopenia basically is related to the muscle. So when I say the muscle, it's the structure and the function. So the loss of skeletal muscle mass and a decreased muscle strength with decreased function because of this. So predominantly we are going to look at some people claim that you should emphasize more on the muscle strength in association with that. So it was in 1989 that Rosenberg gave this definition, a Greek word for flesh and for penia, loss, an age-related disease of muscle mass with geriatric population. However, 2016, it got assigned as an international classification of disease. It got a code as late as 2016. And no global consensus definition are available because there are different regions, centers like Europe, etc., which I'll talk about. And there's little evidence of knowledge translational into clinical practice still with this. So one of the first one was as usual from the Europe. It was the European sarcopenic group as early as 28, 10 and 18. They started talking about, they defined the sarcopenia with low muscle mass, low muscle strength and impaired performance. And then they shifted the focus to emphasizing muscle strength as a primary criteria for sarcopenia. And then the American group, they introduced a diagnostic Asia, that is the third one is the Asia group as late as 2022. They came out with the South Asian definitions, etc. Now, I'll give you a little introduction before I get into the children part. So when I talk about the factors which affect any skeletal growth, so it is right from a small child. We know it's going to be the maternal nutrition. So we've looked at preterm, small for gestational age, etc. So maternal nutrition, We're talking about the genetic factors. We're talking about the postnatal nutrition that is going to be given, the physical activity, and of course the endocrinal factors such as growth, sex. All this gives rise to it. I've not talked about the disease in this. This is a typical factor which anyway affects the skeletal growth. Now, what would be the other factors which can influence is going to be the disease related effects. So, the disease related metabolic syndromes, endocrine, neuromuscular, chronic inflammation. So, liver comes number one when we talk about the chronic inflammation, organ failure, malignancies, disuse immobility in some children, increased hospitalization. So, again, patients who have repeated hospitalization in liver disease as compared to those who are chronic liver disease without those, so they will have a higher morbidity and for complications, which is the surgical transplant, and I'll take you through the studies what I mean. And then the other vitamin D deficiencies, gut microbiota, malabsorption, giving rise to not only malnutrition but also the undernutrition, but also the micronutrient deficiencies. All this will have an impact on the pediatric sarcopenia, which is the muscle mass and the muscle quality, that is the function. So, what is happening in liver disease is the mechanism that is going to be talked about is the inflammation and hyperammonemia, malnutrition, decrease intake, and the hormonal dysregulation, which we've been talking about, the growth in the CLD patients, the growth hormone and IGF-1 axis versus frailty. So there is a big difference between sarcopenia and frailty. Sarcopenia is one part, it's one ingredient of a recipe. So it's the muscle. Frailty is the complete thing. So that would include not only the physical part, but it includes the neurocognitive part, the psychosocial part, the function part. So it's like a complete interplay. That means sarcopenia could be with or without frailty, but frailty has to be with sarcopenia, because that's the interplay between the physical, which is the muscle sarcopenia, cognitive, nutritional, which would be the micronutrient, and the psychosocial domains, anxiety, depression, the other factors, loss of school, the effect by the other your colleagues in school not keeping you off with them. So this I've already talked about, that in cirrhosis, so as I said, there is inflammation, and then there is malabsorption, malnutrition, and the ammonia. All these components with your IGF, they are giving rise to sarcopenia. Now, what are the assessment tools? Now, these assessment tools, general I'll talk about, which is very easily available for the adults, and then I'll focus on the children. So when I say anthropometry, so we've been just doing anthropometry. First case, I just depicted weight, height, weight for height, midarm circumference. I did not say anything more. So that is the way we talk about anthropometry. But actually, that has its own limitation, because weight may not be reliable. So when I want to talk about the muscle, the sarcopenia, then I need to talk about the DEXA, which looks into the muscle mass, or the CT or an MRI, which is talking about the muscle index. And that's what I showed in my patient, psoas muscle. So that's typically used in children. Then even now they've moved over to ultrasound muscle based thickness as more evidence is coming, but initial studies were all with CT and MRI, and still in children we do not have the ultrasound norms. Then you want to look into the function. So in older children or in adults, you look for the hand grip, the functional sensitivity. And in frailty, some of the American centers have modified what is available in the adult and called it a pediatric frailty index, where they will look like a speed, 6 minutes walk, the speed test, the grip, standing with the on behind the chair. So these are ways of looking at the activities that they've looked into. The 6-minute walk test for older children, and the nutritional assessment has to be the global assessment, not just the anthropometry, the micronutrients and the other multi. So this is just talking older group, so for them it is easier. The South Asian group have looked into more and talked about that you should look into the biochemistry. So they've included the other factors, like, which I said, the micronutrients, as you can see, magnesium, calcium, vitamin, creatinine, CPK, and all the. So they have called this in the. But now coming back to the obstacles in children, there is lack of uniform definition, diagnostic criteria, wide heterogeneity, lack of age specific and gender specific norms in a region. If there are something available, it's in the Caucasians, it's not for uniform. And how it will change, because the data which is related to assessment of muscle function and the muscle strength, this is a key feature which adults are defining, which we are still lacking. So what we typically do is the pediatric psoas muscle area, which is assessed at L3, L4 or L4, L5, and the reference value of this from 1 to 16 years, they were published as late as 2020 and now these are the ones which have been published, are being used, and the sarcopenia is defined as less than the -2 standard Z score, which is less than the 5th centile. And these are the standards which I'm talking about. So what I looked in my patient was based on this standard, that you look into the CT psoas muscle area. So other assessment is, I want to know the muscle mass. So the muscle mass is measured by the DEXA or the bioelectrical impedance. Very easy. All of us go and stand. We get, I'll talk about in this next slide. So you get all details: fat percentage, protein percentage, fat-free percentage, water percentage. So psoas muscle index, this is the psoas muscle area divided by the height. So this is what they've used in children. And the skeletal muscle, which is your appendicular skeletal mass divided by the weight. So this is the bioelectrical, which I said it will tell you everything, the fat mass and the fat-free mass about it based on the conduction that happens through it. There is normative curves for the skeletal muscle mass by DEXA. So this is a UK, which is for the Caucasians. So they were smart to give between 5 to 18 years, because you need to understand an adolescent is growing. So we need to see their muscle mass based on the growth that they are going to get, and based on like the BMIs, and they are going to have even the fat-free reduction. The muscle grows in adolescent. So based on that, they came out with this norms that is available. And as I said, frailty is multidimensional, which is a component. And so it is not only the sarcopenia, besides the sarcopenia, the rest of it, the metabolic, walking speed, activity, chronic undernutrition, micronutrient, they compose the remaining part of a frailty. And any three of the following, which they say: shrinking, weakness, poor endurance, slowness, low physical activity. So between the concept that was used in adults, they used in children: grip, walking, body constitution, and some questionnaire, because they don't have self-reporting. So some questionnaire. This was done again by a multi-centric study in 2018. And this was one paper on biliary atresia, which talks about the body composition of infants, like my first case of biliary atresia. There is poor correlation between the CT-based body metrics and mid-arm circumference. So anthropometrics are not reliable when you want to talk about sarcopenia. In such patients, there's inconsistent correlation, even in children like in adults. So few of the studies, I'll rapidly go through. These were the ones which are showing that the in the children, anywhere between 25% to 50%, that high incidence, reduction in the muscle mass or increase in the fat, reduction in that. So these are the ones. They've used, if you see, predominantly people have used total psoas muscle area. First, third, fourth. So they have been using that, and some of them have used the DEXA with the grip strength. So now let us talk what is the outcome. So what if it happens? So the outcome is related in both ways. Now these studies showed that sarcopenia, and they do not correlate to the PELT score. So your MELT score and PELT score will not include sarcopenia. It is independent of that, but the patients who had more sarcopenia, they had relatively higher morbidity issues predominantly, except one study which talked about the post-transplant death. Majority of the studies talked about morbidity in terms of hospital stay, length of ICU stay, increased infection, recovery time delay. These are the ones which are correlated with this, and we see this every day. What the patient who's frail takes a longer time into, but frailty is associated more with mortality too. So these are the other studies where they looked into, at that time when we didn't use MA, SLD, NAFLD studies. I'm talking of children, less than 20 years studies, whatever. So they say that, even having a fatty liver, you're not moving, and that can also give rise to increased incidence of sarcopenia. So it's not always associated with undernutrition. And this study, which I said, though talked about mortality, one study, but in this, I feel maybe the judgment with frailty and sarcopenia was not too differentiated, because it's the frailty which gives rise to increased risk of death as compared to the other. So to summarize, I just put it in one slide, like different studies, what they were showing. I've put the studies at the top, and so they showed, see, length of stay, duration of intubation or hospital stay, long-term growth delay, readmission, infections. One study talked about the death, but majority talked or morbidity issues with them. And so the outcome is there is increased post-transplant morbidity in that, and no significant correlation with retransplantation or rejection. In fact, transplant will be a cure. I mean, that will end up improving it. So I think they have a very important decision on listing the patients, especially for transplant. And maybe it's time that in the PEL scores too, they should be trying to give scores for this. So the scores underestimate the risk in sarcopenic kids, and the post-transplant survival, complications, infections, encephalopathy, rehabilitation, recovery seed. So going back to my patient, of course, her length of ICU stay was much higher, length of ward stay, that is, was also much higher, and she had abdominal infection too. And earlier to that, when I looked into my our data, which is into the less than 10 kgs and more than 10 kgs, we showed that -3 scores were quite higher in the babies who were low. You can see malnutrition, then minus. So literally more than half of the babies who are small are malnourished when they come to us, 60%. Whereas if older children come to us, and I'm taking CLD, I'm not including ALF in this. Whereas the older children who've come to us, 70% very relatively, maybe because the indications are CLD, Wilson's, etc. So I'm just trying to highlight the difference and talk about the same thing I've depicted in that. So what is the importance of this? Importance is both in identifying, because it's a double-edged sword. If I delay transplant, it will not get better. But if I do transplant, the outcome is going to be worse. So the key is in identifying them and trying to intervene before. So how will I intervene? Intervening is, one is what you can do. So one is nutrition. So high protein, energy drinks, night feeds, micronutrient replications. Then talking about the physical therapy, or not only the occupational therapy, physiotherapy, resistance training, use of branch chain amino acids in children who have recurrent encephalopathy-like features, and a multidisciplinary approach, which I said psychologist, because these patients need a a holistic approach and not just a approach by a liver specialist. Ending up the time at yes ending up this is the last. So this child, like, I'm waiting, I'm doing the nutritional rehabilitation. So the key takeaways are sarcopenia and frailty in CLD are relatively new norms, and in children also recent studies in the last less than a decade have started focusing on sarcopenia rather than the anthropometric based undernutrition. And I've defined the difference between sarcopenia and frailty. The commonest one that we use is the psoas muscle area in children, and the other assessment tools, which is the mass through the DEXA or the index or the bioelectrical analyzer, and they have higher morbidity issues and also mortality, especially in the waiting list and post liver transplant, especially if they are associated with frailty also. And early detection and intervention may help you to determine a good outcome for these patients which you need. And of course, liver transplant will reverse the growth failure, sarcopenia, and both health. And so future direction, we need to integrate this in the risk stratification and look prospectively in pediatric cohorts both in different parts of the globe, and come out with some standardized definitions and tools in children. And that way the references I quoted. Thank you so much.
Thank you, Neil. You missed my tea. I was going to go for the tea. So that's why I was hurrying you up. Okay. Thank you. Please join. Okay. Yes. Who needs this introduction now? Yeah. Anyway, Anshu.
It's my pleasure to invite Dr. Anshu. To invite.
Okay. So my topic is basically liver malignancies in children, changing trends and risk factors. And I would like to say that when I was given this topic, I was really confused as to what I'm going to talk about. But then when I started reading, I think there is a lot of literature which has come in this area. So this is a entire world's data, basically 2022, 0 to 14 years of children. And as you can see, that liver malignancies are basically the 7th most common malignancy in children. Now, as we all know that in contrast to adults where it's basically HCC, liver tumors in children can be classified as benign, malignant, infants and young children where basically it is hepatoblastoma and hemangiomas, or in older children where it is mainly hepatocellular carcinoma and its variants. But there are a lot of tumors. But again, what this thing shows you that it's a collective evaluation of all liver tumors. And what is evident is that amongst the malignant tumors, it's basically hepatoblastoma and hepatocellular carcinoma, which account for about 90% of the tumors. And the entire literature is basically centered about these two tumors only. Rest all are really account for a small minority. So this is a registry from the hospitals of India. It's about 60,000 cancer cases in patients who are less than 19 years of age. And they evaluate, this is 96 hospital-based cancer registries. And as you can see that in the 0 to 14 years of all malignancies across ages, 3.2% were less than 14 years, and about 4.6% were less than 19 years. And again, liver tumors, even in India, accounted for about 1.2 to 1.5% of all pediatric malignancies. And amongst that 1.2%, hepatoblastoma was 73%, and HCC was 22%, and the others were 5%. Again, to say that it's just hepatoblastoma and HCC. What are the difficulties in evaluation of the trend? First is that overall these tumors are rare. The global incidence is very low. Second, the data on hepatoblastoma from the low and middle income countries where maximal 80 to 90% of all hepatoblastomas occur. The data from these countries is very scarce. Most of the data is from the US registries, and also these registries don't cover 100% of all cases. The studies have looked at overlapping time trends, and it is difficult to differentiate whether the trends are because of improved diagnostic and reporting or whether it is because of actual increased incidence. So this is a systematic review of all liver tumors in children over a period of 19 years, where they have taken the time trends over a period of 18 years. And this thing will come as repeatedly. This is the annual percentage change, like how the trend is going. So what they have shown is that there is a slight trend of increase of all childhood liver tumors, but this is mainly constituted by the hepatoblastomas, whereas for the HCC, the trend is down. And if analyzed by region wise, there is an increasing trend for liver cancers in the developed world, which is North America, Europe, and Australia, whereas in the trend in the Asian countries is kind of stable. So the incidence overall is increasing for childhood liver cancer, and most common is hepatoblastoma, and there are differences across the regions country wise. So this is what has been shown, that hepatoblastoma is increasing, whereas HCC is remaining almost constant by the forest plot. So now again, this is kind of looking at only the hepatoblastomas from 1990 to 2021, a trend analysis. And what it shows is the incidence, the mortality, and the disability adjusted life years from 1990 to 21 are all decreasing. The decrease is much more in males as compared to females, but the maximum number of hepatoblastomas are seen in infants less than 28 days of life. Although the high income countries are different because they are still showing an upward trend of hepatoblastomas, and I will come to it why. So the lower incidence, mortality, and the disability adjusted life of hepatoblastoma is there, and that has got a significant correlation with the financial status or the developmental index of the country. So as you can see, this slide is important because you can see that the lower income countries at the top are having the highest incidence, but the things are going down. Whereas the high income countries have a lower incidence, but their graph is going up. So when we see hepatoblastomas, the major group is by the low and lower middle, and there the trend is going down, but the reverse is being seen for the high income countries. Again, global data, less than 28 days, the babies are having the maximum incidence of hepatoblastoma at this age. And this is similarly shown across the world in the graph, and you can see that it's mainly the countries, the North America and Australia, which are having a red or the increasing incidence of hepatoblastoma, whereas the developing world has a lower trend. So when we look at it, what it has been shown is that in 2021, it is the lower socioeconomic status countries. The West Saharan Africa had the worst hepatoblastoma burden indicators. China had the highest number of cases, and India has the most deaths. So despite the fact that we are having a lower incidence, our outcomes are still poor, and there has been shown that beyond 2006, the decreasing trend of hepatoblastoma has also slowed down, especially in the developing world. Now, this is basically US studies where they have gone and looked at the hepatic cancers in US. And what they have shown is that it is hepatoblastoma and mesenchymal tumors which are increasing, whereas the incidence of HCC has remained kind of stable, and they are more common in boys as compared to girls, and hepatic tumor incidence is maximal in children who are less than 4 years as compared to the older children. Now coming to hepatoblastoma, again US based data, it is showing that the incidence is increasing over time, and the survival also is best for those who are less than 2 years of age as compared to the older children. And obviously, this is expected that those who are coming with distant disease would, obviously metastatic disease, would be having a poorer. And then again, there are racial differences, that the non-Hispanic blacks are doing worse as compared to the whites, which is well expected. Now, why is it so? This is an interesting study from Japan, which has shown that there is a significant increase in the registration incidence for hepatoblastoma over time. And hepatoblastoma with low birth weight, less than 1500 grams, represented 16% of their cases. And they have attributed this increase in hepatoblastoma with low birth weight babies has become evident after 1990. And this may be due to the NICU stay that they are having, prolonged oxygen therapy, TPN, radiation, multiple have been implicated, or is it that the very low birth weight babies and hepatoblastoma shares common genetic environmental factors, and also some association between maternal preconception smoking with hepatoblastoma? Roughly, there is a 20-fold increase incidence of hepatoblastoma in very low birth weight children, and double the risk in those who are 1500 to 2500 grams. So basically, you can see that the odds ratio of having an hepatoblastoma and the low birth weight, the odds ratio is ranging anywhere from 9 to 69 across various countries. So a low birth weight, very low birth weight babies are a definite risk for having hepatoblastoma. This is comparing the adult versus pediatric HCC in USA, and as you can see, that the incidence in children is much lower than the incidence in adults. The incidence is stable. Children are often diagnosed with HCC at a more advanced stage, which is perhaps because of the fact that they do not have an underlying cirrhosis and therefore they are not screened. But despite that, the survival rate for children and adolescents is much better than the adults. That's again because they don't have an underlying cirrhosis, and so they are operated more often and they don't have the comorbidities. So this is exactly what it is showing, that the survival is better in children. The survival obviously depends upon the stage of the disease, and again there are racial disparities when we look at these children. So what is the way? Can we do anything to reduce? Only universal hepatitis B vaccination is the only way to eliminate hepatocellular carcinoma, and this has been beautifully shown by studies from Taiwan and also a RCT where they had cluster randomized people with HBV vaccination versus no vaccination, and they found that those who were vaccinated had a much, much lower risk of having a HCC. Now, the second thing where we can really intervene in terms of prevention is MASLD and HCC. MASLD obviously is seen in about 10% of children. Its prevalence is increasing at an alarming rate. And this is a very interesting study which has shown that for each unit increase of the BMI in children at 7 and 13 years of age, the odds ratio, the hazard ratio of developing HCC as adults increases to 1.2 to 1.3. So higher BMI in childhood increases the risk of primary liver cancer as adults. Liver cancer in children has just 1 or 2 case reports are there. But this is a study in adults where they have looked at all HCCs, and they have found that the HCC which occurs secondary to MASL accounts for about 15% of all HCC. The proportion of people who are having HCC secondary to MASL is increasing over the last 10 to 20 years. And patients with NFLD related HCC are more likely to be non-cirrhotic and less likely to have undergone surveillance. So basically what we need to do is that we need to have some active intervention for the rising obesity epidemic which we are seeing, and maybe develop some strategies for screening these patients, for which we have actually not screening them because they are not cirrhotic. So what are the reasons for the rising hepatoblastoma in the developed world? We have already discussed this. Enhanced survival of these premature babies with very low birth weight. Population level trend of rising maternal age, that's also one of the reasons incriminated. And then we do not know whether it is innovative technology. We are detecting more hepatoblastomas and that's why we are reporting them more, or actually it is actually occurring more. What is the reason for the stable HCC? That's perhaps because there is a decrease in the hepatitis B related HCC, but at the same time, the metabolic and genetic risk factors related HCC is remaining unchanged. And so the kind of incidence is leveling out at the same level. There is a very limited knowledge of the etiology of childhood liver cancers, and that's actually inhibits us from understanding and interpreting these incidence trends very clearly. And there is a need of ongoing monitoring of these incidence trends. There are a long list of high-risk conditions which are associated with hepatoblastoma, lots of genetic conditions apart from the very low birth weight babies that I have said. And for hepatocellular carcinomas also we have inherited liver disease, a very unique group which we all need to be aware of, is the vascular liver disorders, whether it is Abernethy, BCS, or post-Fontan. Post-Fontan is coming up as a very important group. And then there are a lot number of inherited liver diseases, especially tyrosinemia, BSEP, TJP, which have got a high risk of developing malignancies. So when we are evaluating, there are certain points which we need to keep in mind. One is that if we need repeated evaluations, then MR of the imaging, MR is preferred. And even if we are using CT, there are certain CT pediatric specific protocols which should be used when we are evaluating these children. The LIRAD scoring, which is classically applied for the HCC, is not applicable for children less than 18 years and those without cirrhosis. So we should not be applying these for our diagnosing our patients. And for the high risk conditions, there are guidelines for each and every condition. So we need to, once we diagnose that, we need to look up and see what is there. Because I was surprised that in FAP, there is a 7,500 times increased risk of hepatoblastoma. And they say that every 3 months from the birth, if you have an diagnosed child, then you should be doing alpha fetoprotein and ultrasound, which I don't think I was aware or I was doing. So there are the recommendations are there for each and every high risk condition. So if you're diagnosing a child, look at the recommendations. Then the difficulty arises when we have patients like GSD, where multiple SOLs can occur and both benign and malignant can coexist in the same patient. And you can't go on sampling 20 adenomas to see which one of them is malignant. And they will not have a rise of AFP also. So we, in contrast to adults, we have to have a lower threshold for doing biopsy. And then there are specific immunohistochemistries like beta-catenin, HNNF related adenomas. Now those are being used to predict the risk of malignancies. So when we are doing the biopsies, we have to ask our pathologist to put up all these things. We have to be aware of terminologies like atypical hepatocellular neoplasms and others. And in vascular disorders, we need to keep in mind that radiology is not useful because of the differential blood supply. The contrast enhancement cannot be interpreted. So when we are having vascular disorders and SOL, histopathological examination becomes of paramount importance. So to conclude, I would like to say that overall liver tumors are uncommon. Hepatoblastoma and HCC are the most common malignant tumors in pediatric age group. Majority of cases occur in Asia and low-income countries, but they are not being reported well or diagnosed well. Hepatoblastoma is increasing in the high-income countries, but their survival is now more than 80%. Maximum cases are in the infants less than 20 days old. And hepatoblastoma, though reducing in low-income countries, still has a poor outcome and excessive morbidity, and we need to work for it. HCC is stable. That's basically because of the good vaccination. And I think HBV vaccination and nipping MASLD in the bud can go a long way in preventing HCC in children. There are various high-risk conditions which pose difficulties in diagnosis. We need to be aware of that. And we actually need to have a very good cancer registries and have centers of excellence for management. Thank you very much.
Would you like to join there or? So I don't know. I think we are over time already. Because there's nobody coming to this room. We are over time or no?
No. Nobody will come here.
Nobody will come here.
like we are last now.
So I'm mindful that.
There's a GPM, I think.
Okay, so
That is down.
I'm not a member of INSL, so it doesn't. I'm not invited. So if you guys need to go, maybe if you are the members of INSL, may I request please go. Otherwise, I will be accused of taking people out of the GBM. So let's do that. Okay. Questions now. Abba first, yeah.
To Anshu, is there any link between hepatoblastoma and in vitro fertilization, or is it just that they are very low birth weight and therefore, because I've seen two patients and I once heard Mohammad Rela also say that he had noticed, I don't know if Anil has, but is there anything described in literature, or is it that they're all anyway low birth weight and therefore that is a confounding factor?
I have not come across in vitro fertilization, but increasing maternal age is definitely incriminated. Obviously, in vitro fertilization, mothers are likely to be of a slightly older age, so I can't say that.
Our recent patient who was a 1.3 kilograms baby, so who had hepatoblastoma, had a in vitro fertilization. Yeah. So whether it's just in chance, I don't know. Okay.
To Poda sir, regarding the immune activation in indolent ALF. So, isn't it so that it is seen in all ALF? In the sense, all ALF have this immune activation. So, nowadays we do plasma exchange as one of the therapies. So, what is different in indolent ALF having excess of immune activation compared to other ALFs? Sir?
No, this is a specific entity. They said that CD8 T cell positive hepatitis. So actually, the concept came from that entity that I said, no, aplastic anemia following hepatitis associated aplastic anemia, where they have definitely shown that CD8 T cell is responsible initially liver and then bone marrow, giving high dose of immunosuppression helps. So what you said, that immune activity, this is non-specific immune response. That's why they showed the clonality of that T cell, and they said these are monoclonal. That means it is a antigen driven. What antigen we don't know. Maybe started with some viral infection that has driven that antigen, and that has given rise to this CD8 activation.
So
Sir,
can I comment on it, sir? So Ujjwal, I think the field is not clear. So these two papers on small case report has come. This phenomenon is known for 25, 30 years. So SIL2 activation, CD8 positivity is very well known in acute hepatitis, because pathologists will say this all necrosis. I can't tell you what is what. So they got this to everybody's attention. In terms of, if you look at the clinical implication of it, aplastic anemia can come before or after acute hepatitis. So it's both ways. We believe, and others believe, that it's a viral trigger and in the setup of a particular immune deficient state. So our approach has been hitting them with ATG. So we treat ATG. We don't waste time on immunoglobulins or cyclosporin.
ATG for only this
Aplastic anemia associated liver failure. So that's where, because that will treat the aplastic anemia as well, because IV immunoglobulins are good, but if there is no severe liver dysfunction, then the aplastic anemia people will do that. I think we need more data till at the moment. So I wouldn't call them as entities as they're sold, because previously they were seen as non-specific hyperinflammatory syndromes in the bracket of HLH. So that's where they came. And HLH was treated with massive immunosuppression. So now these patients do have activation or hyperinflammation everywhere. How do we treat them? Steroids will do everything. It will kill every single thing. Or their targeted therapies showed ipilimumab usage. But I think we need more data. The problem is, fortunately, the condition is uncommon. That is the big positive for us. The downside is that, getting a hard data is very difficult. So.
I share my experience as a resident with Professor Walia. We had seen during MD a child who had hepatitis B infection and had anemia, and he proved to be a plastic anemia actually. That time, it was 1985. That period was there, but we didn't know how to deal with the case that time.
I think it continues to be a problem, this particular.
So I just wanted to ask, when we think about giving steroids and a lot of things where you get stuck with immune and all, is there a concern that steroids can, I mean, already the liver is not functioning. So how much time would it take for steroids to like have a little effect on steatotic like, or more infections? Is there anything concerns in that way, which will further deteriorate? Because
I have to give a declaration. We are a very old-fashioned unit, okay, and we don't change that fast. So because things have worked for us, so when people are throwing steroids on indeterminate acute liver failure, we have not done it, but the outcomes are not different. Our patients have same outcomes with or without steroids, so we haven't jumped on it. We have only jumped given steroids or ATG when we have a definite activation like HLH picture. Then only, otherwise not. So we have stayed out. It's maybe old fashioned. We haven't done it, and we are reluctant to change things. And we only get 10 acute liver failure a year, which are indeterminate. So there are not that many. That's the problem. I think there is a merit in it, and also we don't have a focused infrastructure to research on it because of the rarity of the condition. It has to be consortium work like Americans have done. They have hundreds of patients, so they can do it. But if you're a unit that only sees 10 a year, it will be very difficult to come.
One trial is registered with the
Yeah.
to treat ATG.
So they are doing ATG, yes. Yeah. Yeah, they are doing that.
Yeah.
So that trial.
So in continuation with what you said, in the last year ASLD there were 2 oral presentations. So 2 of the centers are actually working on that. One is from the Chicago group and one Sick Kids also. So they both are working, and now other centers are also adopting the same thing, that do the biopsy immediately if the patient is indeterminate, and if CD8 staining is there, if it is positive, so then just give methylprednisolone. And so now they are adopting this, but so you are right that there may be concerns related to infection. So how can we adopt? And and what China Keshav has asked, so that question was also in my mind also, that hepatitis A possibly, with what we see commonly, also may have almost like a similar response, although it is they have shown that there is monoclonality, but we have to prove that the indeterminate and hepatitis A are similar or different.
My advice would be to do the trial. So then everything is controlled. You get an outcome which is good or bad. But anecdotal treatment doesn't change anything.
So those patients who are treated, they excluded infection. What you are telling, hepatitis A positive, last is not obviously you exclude infection, including viral infection. Then only you put this patient on methyl.
So the problem that we have encountered is that these patients, it is so difficult to do any kind of IHC, and even flow cytometry is very unreliable. I mean, we have discussed this with our histopathologist, and what happens is that there is hardly any liver left. So you do the TJLB, you get some tissue, and everything is just necrosis, and you don't get any tissue for IHC. And you also cannot subject, I mean, we've tried subjecting it to flow also, and that also does not work. So to prove the CD8 theory is difficult, and we've had patients of aplastic anemia or hyperplastic anemia, severe, Keshav would remember. And the problem is that we think about ATG, and they've got such bad infections, they just die off. I mean, you can't, before you think of doing anything, they're gone with infection.
I think you do it a study, then
So very difficult entity to actually study.
3-4 centers, you have enough volumes.
Nowadays, for some reason, are you all seeing? I mean, this year in the last 6-7 months, I mean, the amount of hepatitis A that I've seen is more than 1.5 times that I would have seen in the year. So you all have seen. A, sir, it is that's exactly because the change of the like we've gone from the lower high endemicity to middle and better, because we're improving economy.
Yeah, and ma'am, we are
so
seeing,
now we are getting children. I mean, I can't believe it. Every day there's a liver failure in the ward.
and we are
day.
seeing from
Never happened in the past.
from regions where from where
And no, they don't. Hepatitis A, 85-88% survive without transplant.
That's what they say. What my worry is, when you have a transplant as an option, there is always a tendency, not from the doctors, from the family. They may ask you, badal de liver inka. So that is what resistance, what I want to say, that we may be over transplanting, and that is not us.
One clarification. What are the investigations you suggest to us for assessment of the nutrition post-infants children?
So basically, when we no. So for sarcopenia, it's only one, sir. CT, looking at the psoas muscle area. That's what I said. The most common thing followed, and anyway, we do pre-transplant a CT anyway for doing a CT trophic angio. So we always, so retrospectively now we are looking at all the patients' psoas muscle area. So that is number one. Number two, what you asked, nutrition is you should be ideally looking for all the trace elements. So we do whatever is best, like magnesium, this thing, RFTs, creatinine, vitamin E, vitamin A, as much as your call to do. And now they give you a little subsidized cost when you ask for all the vitamins together and pan.
Okay,
Sir,
can
we
I
have,
final word
so
from
we have,
Rajiv? Yeah.
so we have already done a study on sarcopenia. I would like to invite Prapsaran. So Prapsaran has done, so she can add her data.
Okay, so final word from you, not from Rajiv.
So actually, we had come up with this idea of diagnosing sarcopenia using modality other than CT, because exposing the child to CT is, and plus we wanted to do a therapeutic trial also. So doing CT twice was not an option. So we had used ultrasound based biceps and quadriceps thickness, and we did use anthropometry. We calculated the midarm muscle area using midarm circumference and tricep skin fold thickness. So we used these two modalities, and we found around 40 to 50% was the prevalence of sarcopenia in our but we did find a correlation with the disease severity, which somehow has not been reflected in most of the studies, where they did not find association with the PELD score or the disease severity.
So, yeah.
But we did find that the patients who were sicker
So
were more sarcopenic.
the
So
PELD score wouldn't work. It doesn't work in children anyway. It's
yeah.
called pediatric end-stage liver disease score, but it's a creatinine there. And if you have no muscle, the creatinine is not going to be low. That's what the women got discriminated in the MELD score. So they put sex into the MELD score testing. I think it was fantastic. Thank you.
Thank you.
If you have no more things from the chairs, from the audience, thank you so much.
I just had one question. Sorry, it's for Amha madam. Just uh, when you have a Wilson's decompensated, like we have scoring system for Wilson's ALF, ACLF. We use the new Wilson index. You have a decompensated Wilson's. How do you predict that this because we know that they recompensate with chelation. So how do you predict that this patient is likely to respond to my chelation and will not need a transplant in the
No.
because
So I am biased. Okay.
because usually classically we use them in those patients who come with ACLF, CLF,
See, this is
but
the problem.
as a sick cohort.
You are right.
Uh,
This is only meant for people who are not encephalopathic.
yes.
Not encephalopathic. So that brings, if they're encephalopathic, mortality is 95%. So don't wait.
So, for example, this is just like I have a patient, suppose, who's come with anictric ascites, decompensated cirrhotic,
Anictric ascites and Wilson disease, I won't
genetically
believe the
proven, sir.
diagnosis first.
So,
Okay.
so genetically proven.
Honestly, you can prove it, but I won't trust it because you can't have without jaundice Wilson coming to you. That means there is something else causing, and is Wilson by genetics, but liver failure is caused by something else. That I don't know. Ascites is a liver failure to diagnose with synthetic failure, not by
So
ascites.
the patient had like coagulopathy INR of around 2, came with gross ascites, jaundice bilirubin was 2 milligrams per deciliter, and albumin of 2.3, 2.4. We sent the genetics exome compound heterozygous ATP7B. We started on chelation. It was diuretic responsive ascites. She started and the enzymes from 200s AST/ALT came down with chelation to around 50 to 60. Now 3 months down the line, the patient has come with an SBP. So my question is that do we have enough prognostic markers to predict recompensation in decompensated Wilsons? Well, should you subject them to a transplant
yes.
immediately? Or should
No.
I wait
So the
for this
problem,
patient to?
let me tell you two things. Transplant is a disease. Okay, it's not a cure. Okay, just remember that first. Transplant looks very exciting, expensive, everything, but it's another disease you're giving. That's great for the community because you have another patient for life, because they will need to come and see you. So try to avoid transplant at any cost. Okay, when you the patient you are describing not encephalopathic,
Yes.
I will be questioning. Why did the patient come by the SBP? Means ascites control wasn't good. If without ascites, with ascites control, you shouldn't get SBP. If it's SBP, that's a predictor of mortality
Yes.
in a year's time, but not for treatable conditions. So here, if this patient has come back, I will still give the chance. If the patient is not coagulopathic,
Yeah.
now, 3 months
Yes.
down the road,
Yes. Yeah.
then I think I will continue
We'll wait.
chelation. And also, the important thing you remember is compliance to the medication. Are they taking the medication? They're expensive. I don't know how expensive they are, but children don't like these things. And if they're teenager, that's worse. So compliance, I will ask first. I have currently a patient who is from a Middle East, who is for 1 year presented with ascites, is recompensated, has still some ascites, and there is a push to transplant. It's easy for me to get a living donor transplant tomorrow, make some money at the hospital. But I said, no, you don't do it. So I'm sure you're going to get better. Then several, there will be one who will fail you because they will not. If you look at the index that we published, there are two outliers. One who had index below 11, who needed a transplant, and one more than 11 did better. And also you have to remember is the follow-up of a patient. How long you're following the patient. So if the data is few months old, that's not enough. Because we had a child who compensated, had a score more than 11, and people, my colleagues, felt she's getting better, why do you worry? She's 9 months later, she came with another episode and required transplant. So index does predict something, but it will never going to be 100%. It will be never be 100%. If it's 100%, don't trust the data. In humans, nothing can be 100% because biology is so different, so many variables. So there is always room for error on both sides. Yeah. So if this child has improved, go back into it. Whether the urinary copper, what was the urinary copper like at 6 months?
Current last urinary copper is 180. That.
So I don't know what is.
It's a compliance issue.
So it is a compliance issue. It's low.
So we.
It should be high. It should be 400,
Because
500.
I've been drilling about the compliance part. Maybe it's still
So
an
that
issue.
is the reason. It's not the score has failed you. Score hasn't failed you. Score has patient alive. Patient have whatever you want to say psychology. So it's a low. She should have a very high copper
Higher at this
excretion
point.
in the first 9 months, 1 year. Thank you so much. Thank you
so much.
everybody. And Professor Walia, so if I'm your age and I can sit for 2.5 hours in a session, 90 plus, I would be kind of thanking myself, but I don't know. How many of you will think by this age you can stand yourself and concentrate and remember us? I think it's remarkable. Yeah, it's remarkable.
It's really very remarkable. He's 95 Rajiv, oh Rajiv, तो आ जाओ please. ये वाला पैनल का आ गया।